when Jennifer Lewis, who helped start the educational platform for us, said to me and to Christina, her sister slash my partner, she said, I want to do something where the next time we get a phone call, because inevitably we'll all get one at some point of our life if we live long enough, where someone calls us and says, I've been diagnosed, my mom's been diagnosed, my sister has this, something along those lines. Jennifer said, I want to be able to take that call and say something besides, oh my God. I want to be able to say, okay, this is what we're going to do, or this is who we're going to call, or I know where to go, or I know who to see, or I know who to ask who to see, so that the feeling of empowerment is actually like real. And that's what we've tried to do. So if any of you ever have anything that has to do with gynecologic oncology, you now know Dr. Roman, and when we're done speaking, you will know her very well. And you'll leave here being like, God forbid something, I know who to call, or I know how to get to the right person who's going to help direct me in the right direction. And that's the goal of today. And we're going to start, I'm really going to ask you like 3 questions, but you're just going to talk. And Christina, who like I said is my partner, would kill me if I didn't say this. We don't do a lot of big dinners. We don't have enormous fundraisers. Once in a blue moon. This is an educational event. You came because you wanted to. There was no price to come. But I would be remiss if I didn't take this opportunity to say, we're a nonprofit. We work really hard. We're a tiny team. There's literally 2 of us full-time who have done this for 28 years. And we've done a lot. So I hope you leave today being inspired. And I also hope you give a donation.
It has absolutely been game-changing. So what Amy's saying, I can tell you. And the reason I'm involved in this, I'm incredibly busy, is because I'm really seeing the results. So I just had to add. Okay, sorry.
And the reason why, thank you, and the reason why we set up our clinics in the way that we have from the beginning, so our 2 clinics in LA are at USC Norris and LA General, and in New York at NYU and Bellevue Hospital, which is the county hospital next to NYU, is because honestly that's how my mom would have wanted it. She would have wanted every woman who has a history of cancer in their family, who's potentially at increased risk for cancer, to have access to literally the highest levels of preventive care. Like you come through our clinic and you see a doctor like Dr. Roman, who on a normal day you wouldn't even know how to like get in touch with. That's how the world works. And we wanted all women to be able to have a mammogram, an ultrasound, a gynecologic visit, access to genetic counseling and genetic testing. Some of these things that sound normal to, maybe us, but all women should be able to have that if they have any sort of fear that there's cancer coming to them because of their family history, because they have had cancer, because they're Ashkenazi Jews, so which puts us at increased risk. So that's why we did it, and Dr. Roman spearheaded it all really from the beginning, which has been amazing. So let's start. Yes. Let's kind of start there. Will you just tell us what it is? First of all, let's start with what we do. But importantly, the topic of conversation really today is what we all talk about probably on the phone with our friends and at lunch and complain about to ourselves in the shower, which is this time, most of us are in this time of life, but this time of life where perimenopause and menopause have taken over your brain. And the topic of conversation is hormone replacement therapy, and are there other things I can do to feel better, to have energy, to be living what I felt was normal and now I feel abnormal? Is there a way to deal with I'm all of a sudden crying and I don't know why. I hate my children, but I really don't. I want to punch my husband in the throat more often than I used to. Like all these things that you're feeling that feel very out of control. But I want to talk about that through your eyes. So I think hearing about it through your eyes and the lens of cancer prevention and preventive care is a different twist on the conversation than most of us have. So can we get into that too?
Go at it, yeah. Well, I think I was thinking about how best to do this, and I think in the world of social media and the world of all this hula out there, there's a lot of confusion and misinformation. So I kind of think the best way to do this is get back to the basics. What exactly happens with the menopause, what causes the problems, and why there's some of the confusion. And then we can delve into the cancer impact of all that. Okay, so How many of you know what exactly happens at menopause to cause the issue? I see 2. All right, come on. Yeah, if you know, I'm not going to ask you. So a few of you, but it sounds like most of you don't know what happens. Is that correct? Yeah, okay. So basically, in the female ovary, 2 hormones are made as part of normal function. Estrogen, and the role of estrogen is basically to prepare the uterus and make it be able to accept implantation by an embryo. So it has an impact of building the uterus up, making the lining thick. It's secreted primarily the first half of the cycle. And after ovulation, a second hormone comes in called progesterone that then stabilizes the uterus so that it is now ready for an embryo to implant. So these 2 hormones have to work together, and their entire function is reproduction and pregnancy. That's what they're there for. And they have to work in balance. If they don't work in balance, you end up, when you're young, getting irregular periods and heavy bleeding and all kinds of issues. So for the uterus to be healthy, these hormones have to be in balance. Now, as a woman ages, and biologically, from an evolutionary point of view, it makes sense. How important is the mother? Maybe women past a certain age shouldn't be having children, because who's going to raise those children if the mother dies, right? So as the woman ages and gets into her 40s, and the 40s is the years of the perimenopause, the ovaries start getting lazy. So the brain is going, okay, make another egg, start making estrogen, and the ovary is like, well, no, maybe. All right, I'm trying, but I'm getting tired, right? And what happens, and it's different in every woman, but as one gets into their 40s, the ovary's not doing such a good job anymore. It may start the job, but it may never actually ovulate. So what will commonly happen, usually in the late 40s, is that people's periods start to space out, or bleeding becomes irregular because the ovulation is no longer happening monthly in a clockwork fashion. And now in some women, that doesn't happen, and they have regular periods up until they stop. But generally, for most women, there's this prodrome when the hormones are changing, and women are aware. I've lived my life with monthly periods for like how long, and all of a sudden I'm off. I just feel funny, this isn't my usual cyclicity. Ultimately, the ovary says, I'm done, no more. And when that happens, the estrogen levels drop dramatically. There's no more ovulation, obviously, no more chance to get pregnant. In this country, the average age now is in the low 50s where this happens. And when the ovaries stop working and estrogen levels drop, what happens? Well, the classic effects of menopause are primarily due to the loss of estrogen. Bone loss, vasomotor symptoms. So bone loss accelerates when estrogen drops. Vasomotor symptoms, the classic hot flashes. And classic hot flashes are usually a flush that starts in the chest and goes up the neck to the face and just breaking out in a sweat. The cheeks are often flaming, which is awful if you're in a profession like mine giving talks. And, for professional women, this is not good, right? And of course, a lot of people know exactly what's going on, which makes it even worse. So the other problem with hot flashes, they love to happen at night. They are most predominant at night. The waking up, I'm so hot, throwing out the covers. Your husband goes, I'm freezing, what are you doing? And you're like, I'm gonna burn up, open the windows, sweating, have to almost put cold water on. And then of course it reverses and I'm all of a sudden cold. But the biggest issue
Why does it happen at night mostly?
I wish we knew. The body has a biorhythm. And for some reason, this loss of temperature control. The other thing that happens at night a lot, by the way, is the peaks of anxiety. Yeah. Many times when people are anxious, 2 a.m. is like the absolute time where it's going to be worse. Maybe it's because you're not distracted, who knows, but anxiety also peaks at night. So, our bodies have a rhythm. And vasomotor symptoms love to come at night, so what happens? You don't sleep. So the depression and the grumpiness and taking your husband's head off and hating the world and the crying is really a lot about disturbed sleep patterns. And I have I have had fights with some of the breast cancer male doctors who are like, it's not a big deal. And I'm like, you try this. You try this. You try to come to work after you've been up all night, or sleeping an hour, waking up, sleeping an hour and a half, waking up. So it is a big deal when it happens. It doesn't happen to everyone. There are definitely women who glide through menopause and feel absolutely nothing. And then there are some where these hot flashes, if they don't do anything, can go on 10 plus years. On average, hot flashes tend to die out over about a year, but it's enormously variable, so one certainly cannot judge what's happening to someone else based on their experience. So evolutionarily, from an evolutionary point of view, women, many often historically either died before menopause or lived a very small part of their life in menopause, but in the last 100 years, the lifespan has increased dramatically. So now, on average, women are living a good third of their life in menopause, and that has caused problems. Because other than the hot flushes and the bone loss, what else happens? Increased risk of atherosclerosis, vaginal dryness.
What's the first one?
Increased risk of atherosclerosis.
What is that?
Oh, plaques in the arteries. Plaques in the arteries. Estrogen is good for vascular health. We've long known that women in the premenopausal years have a much lower rate of heart attack as compared to men of the same age. And then the vagina loses not just moisture, but it becomes rigid, it can't expand, so intercourse becomes painful. And I'll be honest with you, you're gonna laugh, but the introduction of Viagra was one of the worst things that happened to older women. Coming in going, what do I do? So it's true, and it's like, I was just like, of course there's no Viagra for women. So
my husband was just at a talk a couple weeks ago where a longevity doctor was there for men and said that one of the things he prescribes to his patients is microdosing Cialis. And he's like, that's what I'm gonna start doing. I was like, are you fucking insane? Absolutely
thanks
not.
a lot.
I was like, literally, that's what they're being told to do.
Yeah, anyway, but so these things really, are the main effects of menopause. So it became clear, for a long time, menopause was something women just didn't talk about. It was silent. You didn't talk about it. In my era, when I was young and in residency, it was the era of awakening and the needs of women, Lamaze classes, and it started to be okay to start talking about menstrual symptoms and menopause, and hormone replacement therapy, which back then was given orally, became a thing. And it became clear that hormone replacement therapy not only did wonders for hot flashes, which is why it was introduced, but all the initial studies suggested there were less heart attacks, there was clear bone protection, and vaginal health was much better. So people got on board, it became popular. I want to emphasize to you that one of the big challenges with hormone replacement therapy, if you have a uterus in place, you can't just go on estrogen. You have to go on estrogen and progesterone to keep the uterus in balance, or else the risk of uterine cancer is extremely high. So bleeding is one of the challenges because, nature does it better than we do, and not every woman, it's easy to find the balance of the hormones that you need. If you don't have a uterus, it's much easier. It's estrogen alone. Obviously, bleeding's not an issue, and that makes it easier. So these are two different, yeah.
Can I ask you a question about that? So people who don't have a uterus that are told not to have progesterone, I'm confused by that because I find that it's so calming to the body, and there's so many other benefits to it. So why wouldn't they use it for those reasons alone?
Progesterone has a lot of harm as well. That's the problem. Progesterone is not good for your vascular circulation, and the combination of estrogen and progesterone increases the risk of breast cancer. Increases the risk of breast cancer.
The combo.
When you put the two together. So, progesterone is also the hormone that gives PMS, by the way, just so you know. PMS, premenstrual symptom. Progesterone. The second half of the cycle is a progesterone dominant part of the cycle. So PMS, bloating, that tends to happen in the second half of the cycle is primarily due to progesterone. So look, every woman responds to hormones differently. I mean, I can tell you what one woman, it's like pregnancy, right? One woman's experience, I never felt better in my life, I never felt worse in my life, right? It's very individual, but from a point of view of being good for your body, progesterone for most people is not particularly a beneficial hormone once pregnancy's out of the picture, just so you know, yeah. Okay, so just so you understand, how you do hormone replacement therapy differs on whether there's a uterus or not. And people go, well, what are the normal levels? Well, in menopause, the normal hormone levels are low. You're not supposed to have hormones in menopause, so normal is low. But what we are trying to do now that women are in menopause so long is it really such a good idea to let all this happen if there's an alternative to prevent it, right? So, but what I think you should know if you have, been keeping up with the news is there was a study, a huge study called the WHI study that was done in the 90s that threw an entire wrench into this whole thing. It was a badly done study.
It was a what?
Badly done study. Badly. I mean, they meant well, but they didn't interpret, the interpretation was problematic, which, in fairness, not on purpose, not a big pharma thing, people just err sometimes. But the WHI study basically took a bunch of menopausal women. There was the group with a uterus and without a uterus. So one got just estrogen, the group with the uterus got estrogen and progesterone, and back then it was given by mouth. And I just want you to remember something. The ovary, when it makes hormones, it puts it directly into the blood circulation. When you put something in your mouth, it immediately gets shunted to your liver. Your liver processes it, and you will have a different effect. So some of you might remember, I'm old enough to remember when the birth control pill came out in the 60s. I was a kid in elementary school, granted, but my 6th grade teacher had a stroke from the birth control pill. Why? They were using very high doses of oral hormones. And what happens when you put a high dose of estrogen into the liver? It increases your clotting factors. Helps the cholesterol profile, but it increases your clotting factors. So the WHI study, it was a randomized study. One group got hormones, the other group didn't. What happens 5 years later?
Both have uterus, or did one not have
One
uterus?
group had no uterus. That was estrogen versus placebo.
Okay.
The other group with the uterus was a combination estrogen and progesterone and placebo. Large study. It was women of all ages. Generally, hormones are started at menopause. This, you could go on at 50, you could go on at 60, you could go, you could be older. So you could have been in menopause 10 years and start it because they were like, we're going to decrease heart attacks, we're going to decrease strokes, we should offer it to everybody. That was the thinking at the time. And I want you to keep in the back of your mind, when estrogen goes away at 50, the risk of atherosclerosis starts to rise. How does atherosclerosis cause a heart attack or a stroke? You have this irregular part of the blood vessel wall. If a blood clot forms on it, it obstructs the blood vessel. The oxygen cannot get to the heart or to the brain, and you have an event. So anything that increases clotting factors and increases the risk of a blood clot is a bad idea as one ages. The WHI study, to everyone's shock, in the estrogen and progesterone arm showed an increased risk of heart attacks. There was also, relevant to your question, an increased risk of breast cancer. It was small. It was, we call the hazard ratio 1.25, so 1.25, so the risk in one group is 1, it was 1.25 in the other group, so a little bit higher. There were 8 extra cases over what they say 10,000 women years, which is 10,000 women each going on a year, or obviously less if you are on further years. But the bottom line is, after 4 years of use, the risk of breast cancer in combination hormones began to slowly rise. And theoretically, if you kept going longer, it would rise more. That is the feeling. So it wasn't statistically significant, but it raised alarm bells. So they stopped the study early and said, this is harmful, black box warning, no more. And all these women who are on hormones were like stopping it. And doctors were all of a sudden saying, all right, if you have terrible menopausal symptoms, we'll give it to you for a year or a few months to calm you down, but then you're coming off. The estrogen-only arm, there was no increase in breast cancer risk. There wasn't an increase in heart attack risk, but there seemed to be a slight increased risk in stroke. So that was kind of also a little bit like nerve-wracking. And it was totally contradictory to the studies where hormones were started at menopause as to what happened. But this was considered a landmark randomized study, and that was it, man. Black box warning, over. At USC at the time, there was a huge division of reproductive endocrinology, and the chair, his whole focus was hormones and what they do to the body. And I remember shortly after, I mean a few years after, him saying, this is everything, this isn't the estrogen, this is when they started it and the fact that they gave it by mouth. Introduce the current way of giving estrogen, which is a patch. This is the bioidentical way to give estrogen, a patch.
Will you explain the difference between bioidentical and synthetic?
Yeah. So while it's not, I mean, yeah, unfortunately, all estrogen is manufactured, right? I mean, we can't take it from the ovary. It's manufactured, but what the bioidentical means is you're giving exactly what the ovary is giving. You're replicating what the natural body would do. So the ovary secretes the active part of estrogen is called estradiol and secretes it right into your blood. The patch is estradiol, that is synthetic, and it's secreted right. You absorb it, it goes right into your blood. It replicates what the ovary does.
And the birth control pill?
Does not. That is an entirely different hormone, and it goes through your liver.
What about the femring?
Femring also gets secreted right into your, it's secreted through your vaginal mucosa. Yes, this is a natural way of absorbing estrogen. The one, it's all about putting it into your mouth or putting it into your rectum, which would have the same because it's a GI, organ, but no one's thought of giving hormones via suppository yet, so thank God, and hopefully never will. But just so you know, from a scientific point of view.
For micronized progesterone that's bioidentical with the risk?
So progesterone's a little, so right now, progesterone is mostly used through the mouth. There have been estrogen-progesterone combination patches that are available. It's interesting, they're available, they're not available. You can get them, you can't get them. There's been a little bit of a concern that the absorption of progesterone is not as reliable. But if you do take a progesterone patch, you are also replicating the way the ovary puts progesterone into the system. Progesterone, if you take it by mouth, has much less impact in the liver than estrogen has.
Why?
It's some drugs, when you put them in the liver, get the liver going, and others, it's literally a bypass effect. Okay, you're good, pass. I don't care about you. But there's some drugs, and you often find out what they are because when you take a new medicine, it'll say, if you take that, you can't take this medicine because it will affect the liver metabolism. There are some drugs that the liver is primed to get hysterical over, and there are others where it's like, you're good, go, and it doesn't touch it. Estrogen has a big impact on the liver, progesterone much less. So it is less of a concern how you take progesterone as far as impact on your body. It's the estrogen that matters, just so you understand. Drugs are different in how they impact you. So what happened with the WHI study was the oral progesterone, especially given years after menopause, turned out to be a problem. And the minute the transdermal estrogen became available, it became clear, whole different ballgame. And there is benefit as far as vascular health and benefit as far as vascular events. But it didn't solve the issue of breast cancer. Because breast cancer has nothing to do with what the liver does. The breasts are a very hormone-sensitive organ. And it seems like the longer one is on hormones, the risk of breast cancer, especially with the two together, goes up a little bit. What is disgusting about the whole thing? I mean, after all these years, we still don't have data. All right, we know it goes up at 4 years. What happens if you're on it for 10 years? What happens if you're on it for 15 years? What exactly is the risk? Does it matter what formulation of progesterone you use? Is it all the same, or does it matter? Does it matter if it's a patch rather than an estrogen pill? How many years later, 20-something years? We still don't know. You can talk to the breast cancer specialists who are involved in this. You can talk to the reproductive endocrinologists. They all go, we don't know. We should know, but I'm going to tell you, women's health in this country and the research is a problem and remains a problem.
So
Yeah.
what's the standard of care today then that you would offer?
Yeah, yeah.
Given the menopause issue, but we have so many women here.
Yeah. So this is what I tell people. You know, I'm just going to tell you that most people who do what I do end up on hormone replacement therapy. I think in our heart we all feel there's benefit, okay? As long as there's no major contraindication. The biggest contraindication tends to be a history of breast cancer or some kind of cancer that is hormone receptor, so that's activated by female hormones. That's a different story, yeah.
What about gynecological cancers?
Most of them it's okay, but there are a few exceptions. There are a few gynecologic cancers that are hormone sensitive, certain kinds of uterine cancer, low-grade serous ovarian cancer, certain kinds of what we call stromal tumors. But most of them it's actually okay. But breast cancer is the biggie. So, you know, there are a few absolute contraindications, but if you do not have that, obviously it's a personal decision, but I think this black box warning finally got removed. They finally woke up, you know, I don't know, it was about a year or two ago. I mean, it was recent. And I'm like thinking, finally, because everyone was doing it. Everyone figured out the answer. People who did their job figured out the answer and was offering it more and more. But the black box warning got removed, and all of a sudden I have 70-year-olds walking in going, can I have hormones? You know, so everyone is like, I want it.
Because they want to feel better, because they want the benefit.
They feel like they will feel better and they want the benefits. And so to answer the question about what to do nowadays, whether, you know, people have definite ideas about putting things into their body and playing with nature, because it isn't natural, right? It's not meant to be.
You're staving off nature.
Yeah, I mean, you're trying to say evolution hasn't caught up yet, so I'm going to take action, how I look at it, right? But I think the first decision is, how symptomatic are you? If you're miserable, you got to do something. I mean, you don't have to, but you should, right? Number one. If you're not miserable and you're feeling nothing, then it is more a decision of, do I want to undertake this for the potential benefits? And that is a personal decision. I don't think anyone can say it is medically demanded or absolutely you have to do it. It's a choice. All of this is a choice, right? You are never going to replicate in menopause exactly what the ovary did. Women are far more complicated than men. There is no Cialis for women, and hormonal function in women is a finely tuned, you know, peaks and troughs to make ovulation happen, to make menstruation happen. Libido is you know, you see it in animals too. They're in heat, they're not in heat. You know, we don't quite do that, but we have these fluctuations in hormones that impact libido. We probably should be able to replicate it in menopause, but nobody has. So you're not going to replicate reliably what happened in premenopause and menopause, but you can stave off some of the more damaging effects. What I tell people is, look, there are benefits here. I mean, there's a detriment to the pocketbook. The breast cancer thing is something to just remember. I'm going to tell you another trick quickly before I forget about progesterone with the breast cancer. There is a progesterone-containing IUD that can be put in the uterus, where it really sits in the uterus and doesn't really get into the body hardly at all. And by doing that, you almost certainly you know, that small increased risk in breast cancer goes way down. So that is called the Mirena, or there's a Kylena IUD. So that is an option for if one goes on hormones and, you know, tries it the normal way and goes, I really like this and I want to stay on this, you know, for years and years and years. It's just a consideration to end this worry about progesterone, since we don't really know what the risk is if you're going to use it for 20 years, is consider a progesterone IUD and call it a day. And just, you know. But I always tell people, remember, far more important as far as what may happen 15 years from now is how you feel today. I mean, I don't think quality of life should be underestimated. And I think the thing is, when one goes on hormones, how do you feel? Do you like it? or do you not? Is it worth, because the problem is if you're on both and you are taking it, in a way that you're taking them both together and you screw up, you're going to bleed. If you forget to take it, you're going to bleed. And then you have to be worked up because we need to be sure it's the hormones and not something else that's anxiety producing. So you have to decide how you feel, your lifestyle, your pocketbook, is worth it.
If you've gone through menopause and you miss a patch or whatever, will you bleed?
Well, everyone's different, but yes, generally, if you forget to put it on, the bleeding comes from the hormone levels dropping off.
Right.
So you definitely might bleed if you get, you.
So if you were, let's say you went through menopause and you were doing an estradiol patch, you were taking progesterone for 4 years, and then you're like, I don't want to do this anymore, I want to see what my body's like, you'll start getting periods?
You won't start getting periods when you stop, you'll have a bleed, and then it should stop and you should be done with it. So it's expected when you stop. That's what causes a period. A period happens when the hormone levels, you don't get pregnant. The corpus luteum that's making progesterone in the ovary, the thing that happens after ovulation, the egg, the thing that secreted the egg becomes the corpus luteum, and that secretes progesterone to support a possible pregnancy. It lives for 2 weeks. If you're not pregnant, it dies. The progesterone level drops, the estrogen level drops, you have a period. So a period comes from hormone withdrawal. So if you're on hormones and you stop them and your blood levels drop, you will probably bleed. So if you're on hormone replacement therapy, it's a good idea not to muck around with those pills because you may end up bleeding unexpectedly, and that's a hassle. So it is, first of all, a quality of life issue. How do you feel? Some people think they feel great, and definitely it will convert, it doesn't convert the face into a 20-year-old face, but it can convert the vagina into the vagina of a young woman for sure. So as far as sexual function, comfort, and lubricants cannot overcome a menopausal vagina because it's about, the vagina has to expand to have a baby and, to have sex comfortably, right? It has to be able to stretch without hurting. Postmenopausal vagina doesn't want to stretch and it tears, and that causes pain. And, also it's very hard sometimes to have a pap smear and pelvic exam and a speculum inserted for a postmenopausal woman. So, these decisions, I very much feel from a health point of view with how women are living nowadays. The use of estrogen, not progesterone so much. The progesterone is needed for the uterus, but the estrogen is the key hormone as far as, health. I will also tell you that the reproductive endocrinologists, many of them, those who are into this, offer women, forms of testosterone to help also with bone loss and muscle mass. The data for this, again, we should have this data. It's ridiculous we don't, but theoretically, it's a benefit. When you ask the breast cancer doctors, so is this bad for the breasts? Their answer is, I don't know. Wonderful, right? Wonderful. Wonderful. And I'm like, does no one care to find out? And everyone says, people are buying it. No one, So it's important to understand for all of you that we do have now data on estrogen and progesterone. We are missing data on testosterone, DHEAS, and exactly what good it does and what harm it may do. So you kind of need to understand it is a big business. There are boutiques out there, and we're going to check levels, and we're going to make you feel like you're 20 again. Not exactly. You're not going to be 20 again, and do you want to be 20 again? I don't know. I don't think I do, honestly, but, but you want to keep it in, context. Yeah, okay, I'm sorry. Let's go on and ask questions.
Yeah, I don't think you answered this question. I mean, there are a lot of people who don't take hormones. I'm a person that does, right?
Yeah.
But I always will know that I don't want to be hijacked by it. When do you go off then? I don't want to all of a sudden go back to, menopause when it was full blown. I was not a normal person.
Yeah.
Brain fog, depressed, all those things. Like, I don't know when to stop. I think there are benefits to taking hormones long term, but you're saying no.
Well, no, I mean, most people, I intend to stay on estrogen. I mean, I'm like, why should I stop? You know, I mean, I think it's good for me. So, no, you don't have to stop. What I do think what you can do as you age is try to lower, I mean, there is no normal level of estrogen as you age, right? A lot of it has to do with how you feel. And I'm always a believer, more is not always better. I mean, I know people who take all these vitamins, they're turning orange, they're taking it. I'm like, why are you doing this? You know, my mother, I'll never forget, she saw some, I forgot what he was in Connecticut, but she came home with these juice pills with like tons more fruit than you could ever possibly consume. And she just was nagging me, and I finally tried it. I was so sick. And I'm like, why would I want to eat 100 mangoes? Yeah, Mom, your body does, more is not better, right? So as you age, what I think you could try to come down a little bit, you know, on the hormone dose. I don't know that we really know if you take estrogen for 25 years, does breast cancer risk start to go up a little bit? Maybe. So what I've done is I've kind of crept down a little bit. The standard postmenopausal dose is 0.05, and I think as people age, you probably could easily get away with doing 0.0375 or 0.025. And if you feel fine, good enough. Good enough. But I don't think you need to feel you have to stop.
Yeah, no, it's always a question. You never want to be hijacked by anything, but I definitely switched from just taking a pill to the patch and progesterone, and I think that it made a difference. I mean, I'm someone who's very sensitive. I don't know about anybody else, but my symptoms were really bad, and I think that, it's scary to think to go back to that.
You may not. I want to emphasize one thing. Just, it may not have. I mean, many people will go on hormones and come off and will not have. It's important to understand, and believe me, when it happened to me the first time, this is when I got into a knockdown, drag-out fight with the breast medical oncologist because I was very grumpy and tired, and he said the wrong thing to me at the wrong time, and I kind of, thank God we were friends for years. I did turn on him and kind of shut up, you know what you're talking about. Stop it. Your patients are not telling you the truth because they're scared to tell you the truth because they're so petrified. You have no idea what you're talking about. Second time, I'd gone on hormones and I came off and I had no symptoms at all. And I've heard that from a lot of people, so I'm just telling you. But how you find out if you feel like you want to try is you don't do cold turkey. You lower and lower and lower and lower, and if nothing happens, you lower further. You don't just tear the patch off.
Yeah, it's interesting that also it's the pink pill. I don't know, you mentioned earlier there's no Viagra for women. There's a whole movie on this about how Viagra was developed for women, and then it changed, and now there's the pink pill. I don't know what about it, but there's a movie on it, and to get it approved by the FDA is a whole big thing. Anyway, just wanted to know.
Women are much more complicated than men and when it comes to sexual function and libido. I hate to say men are much more programmed and mechanical, but they are. And women, a lot of it is what's in the head, to be quite honest with you, and that is a hard thing. Men are much more programmed. And I understand why. I mean, I think when it comes to reproduction and human survival, men, it's just about spreading the seed. Women, it's about security, protection, and they've got to take care of the kids they have. Questions? Yeah.
I don't know if you remember me, I was a resident.
You look very familiar. All right, what's your name?
Rebecca Lane.
Oh, yes.
Hi. Hi. So, and I know you're a gynecologist, but can you talk a little bit more about the you were talking about the effects on the vagina, but I want you to also talk about local vaginal estrogen, which I think is
Yes, another option, right?
And also for women who might not want to take systemic hormones, how that
Right. Yes, so there is one thing, so if a woman either does not want to take hormones that go into the body or there's a contraindication, there is an option to at least treat the vaginal effects of lack of estrogen, and that is a hormone cream. There's Premarin cream and estrase cream. I like estrase cream because Premarin cream comes from horse's urine, and I'm like, why torture a horse when there's a synthetic form? So I usually prescribe estrase cream, which is more just a synthetic form of estrogen. And it is basically applied, and there's a lot of, it's amazing to me when people come in and, it's given by someone else. They sometimes just put it, I don't know if you've noticed this, but they put it on their finger, just put it outside, and that's not what you're supposed to do. It comes with an applicator, and you're supposed to put it all the way up in the vagina, usually before you go to bed. I mean, the rules are you put it up in the vagina, depending, usually we start at 2 times a week, sometimes 3, to get the vagina built up and then back off. And usually you pee, you put it in right before you go to bed and you lay down, because if you put it in and you run around, it'll all drip out. And then it makes a mess and people are like, ew, gross, And I mean, look, it's gonna drip out. It's a little bit messy, but it works. And, so you pick your nights, and the minute you put it in, you go to bed and leave it, and it will do a lot of good for the vagina. In the breast cancer realm, the breast cancer doctors, there was a fair amount of pushback against it, but there's been some recent data that suggests even in women with history of breast cancer, this is safe because very little gets absorbed into the body. This will not help hot flashes. This is not going to help the bones. This is really for vaginal health. But for women who either choose against hormones or cannot take hormones, there's at least something they can do to protect the vagina, and it is very effective. It's just, it amazes me how many women are like, it's gross. And I'm like, oh, come on, you can do this.
But there's also now tablets.
Yeah, the tablets are not as strong. There is a tablet that absorbs much slower, so you don't have the messiness. It's not as potent, though, in my experience, but it's better than nothing. So, there are options for vaginal health, for sure. Yes?
Do you know about the Dutch test?
The Dutch test?
Yes.
No.
So it's a test, my doctor's more integrative, but
Yeah.
it really shows the pathways of how estrogen is used by your particular body. And they said that they can sort of detect, like, okay, the way you process estrogen is sick, and another person might be more prone to cancer.
I mean, I'm not, I'm, do you know?
It's a urine test, so I think they're able to. There's no data that the Dutch test. There's no data, probably because studies haven't been done on it.
Of course.
But,
Yeah.
I think like the idea is that there's some like metabolites of the estrogen that are detectable in the urine that are not detectable in the blood.
But why would they do harm?
Sorry.
Why would they do harm as far as cancer is
I
concerned?
don't think there's actually any mechanistic knowledge about how those are impacting receptors differently. But
Right.
because of that, I don't think it can prognostically be used to say this is something that is more likely to cause cancer in one person versus another. But it might give proof that one person's body is maybe metabolizing the estrogen that you're taking at a faster rate or a slower.
That for sure, I mean, I guarantee you that's happening. People metabolize hormones for sure differently, 100%. The question is that harmful? I mean, estrogen has not, in a healthy individual, the use of estrogen is not alone. As long as there's no uterus, I mean, I would never use this test to say I've got a uterus and I'm going to take estrogen by itself. The risk of uterine cancer is so hugely high if you have unopposed estrogen for long periods of time, right? I would be very cautious about that because it's a profound risk factor. And I would really want to see the data in a large cohort to tell me it's safe. But I think that the million-dollar question is where, and I'd be very interested in seeing the data. If you metabolize estrogen differently, do you need a lower dose? I mean, honestly, how we usually tell what's an adequate dose is listen to your body. How do you feel? Are you getting, vaginal health? Are you not getting hot flashes? How's your estrogen is more about maintaining bone than building bone. It's more like preventing bone loss and building bone a lot. At best, it might build bone a little bit, but it helps prevent bone loss. So what are your end effects, right? And how do you feel? So, because in some women, estrogen causes breast tenderness. One of the big complaints people can have is the breasts get very tender. So we have to kind of titrate the dose. How are you feeling? So rather than a blood level, it's more like, what is your body telling us is happening inside, right? That's kind of the best clue.
I find that estrogen really helps my brain. Like sometimes I can't remember anything, and if I have the right dose of estrogen, all of a sudden I'm like, or what's we haven't talked about that.
Yeah, the brain health issue. I was just talking to, you probably know Donna Shoup, today we were in clinic together because she's a big believer in this. The brain health issue, to my knowledge, has been a little bit harder to pin down. I suspect there's a lot of, the brain is such a complex organ, and obviously quality of sleep and, plays a role. But the brain health issue has been harder to pin down than the cardiovascular benefit. I mean, obviously, if you have better vascular health, your risk of stroke should be less, and, you have more blood flow to the brain. But women are so differently impacted by hormones. I think if you are one of those people where you feel you take estrogen and your brain clears, obviously in you there's something going on. It may not mean that your stroke risk is less, but your brain function has changed. But not everyone experiences this. It's extremely, one of the very common things that happens in menopause, women, generally women can multitask a million times better than men. Men are very, generally, there's exceptions, but men are very, and I remember when I got married, I'm like telling my husband, let's do this, this, this. And he goes, quiet, I'm doing this. Don't talk to me, I'm doing this. It was fine for him while I was cooking and answering pages to tell me what he needed, and talk to me all the time. And I did it. I did 5 things at once, no problem, right? And I think women are just the lifestyle of women. You kind of are stuck, right? You're dealing with 5 things at once. Menopause, that begins to go away. And it was to my shock, because I was very good at doing 5 things at once, that I couldn't do that anymore. And what happened? The keys ended up in the refrigerator, and it was like, where is this? And it would be like sitting around, and I'm like realizing it wasn't working, and I had to pull back. And, so there are definitely things that happen in menopause, and I have not found estrogen has made the slightest bit of difference to that. But I have heard many women say, I feel like my brain's clear. I feel like, and why that is, I don't know that I can say, but there's obviously reactions going on in your body. Your body's all connected that help, right? And I think listening to your body when you do these things, right, is extremely important. It's not for everyone. Not everyone likes the way they feel on hormones, is my experience. So, if you don't, then don't do it. Yeah. Yes.
Okay. Other than the vaginal cream, you have saved, Dr. Lane's incredible and has saved me because I don't make up 10 times in the middle of the night to use the bathroom anymore since I've been using vaginal. If you have contraindications and you can't take the hormones, are there other ways of building bone health and heart health or anything?
Well, yeah. So there are a lot of, medicine has come a long way as far as options, as far as heart health and bone health. So, heart health, the statins, cholesterol, and now there are many other drugs, cholesterol control. And despite what you might think, cholesterol levels and the good and the bad levels have more to do with genetics than your diet. I'm not trying to say that the diet doesn't have an impact, it does. But it is amazing to me how people who can be morbidly obese and have good cholesterol levels, and people can have a very healthy diet and have terrible cholesterol levels. There's a lot of genetics, so you're kind of stuck, The statins definitely, impact the cholesterol ratio, and also there's very good data regarding long-term improved vascular, decreased vascular events with statins. So number 1, the statin drugs. As far as heart health, and all the things, not smoking, blood sugar control, exercise, all these other things obviously are beneficial as well. But statins have been a game changer. Bone health for people who are losing bone, it's very important in menopause, adequate vitamin D levels. Vitamin D more than calcium actually is very important for bone health. And despite the fact that we live in a sunny climate, maybe because we use sunscreen, most of the time, when you do vitamin D levels in women, they're low without supplementation. But, weight-bearing exercise, important. Bone loss is also very much related to genetics. I mean, it's amazing. Do you find that there's some physicians I get to, it's amazing to me sometimes. I'm like, how does this lady have a normal bone density? She's tiny. She doesn't exercise. She's been ill, and her bone density is fine, and someone else who I would expect, So for the bone loss, for people experiencing bone loss, there are all kinds of things they can do. The most common are the bisphosphonates, which can be given orally or via injection, or denosumab, it's called Prolia. They both build bone. Prolia, they're called, the bisphosphonates, it's called Reclast is the IV form. It's once a year for 3 years. Prolia is every 6 months. These are IV drugs that can definitely build bone and decrease fracture risk. So for people who are, getting osteoporosis, and there's a new one called, I think it's Evenity, right? Evenity, yeah.
So the anabolic agents, the ones that are really efficacious for building bone.
The best for building bone, right?
Are Evenity and what we call recombinant PTH. So it's medication that's daily that you take by injection that actually duplicates something that your body does to help improve bone.
With supposedly Evenity, there's a cardiovascular risk concern, right?
So Evenity is a once a month medication that you take for a year, and then after that you have to take bisphosphonate just to consolidate the impact of it. But we don't use it in patients who have had a heart attack or stroke.
Or high risk.
In the last 12 months. 13 months is totally fine. But as long as they haven't had a heart attack or stroke. But if you have a family history of heart disease or a family history of stroke, we can still use it. But we just want to be careful in that.
What about people with like a high coronary artery calcium score, for example?
So I think that that's up for debate. I think that if somebody has a high coronary artery calcium score, it's a tough one because women, no matter what, are going to have lower coronary artery calcium scores than men. So we think of a more risky score as being above 100, but women very rarely are above 100, and we know that our risk is there. And I think one of the thoughts is that women build more soft plaque than hard plaque. And soft plaque is a lot harder to detect on those kinds of tests. So instead they're using CT angiograms to take a look at the vessels in a different way. But I think if you're doing good risk factor modification with a high risk score, then you still could be a candidate for using something like Evenity, but I would probably go with one of the other ones.
They all have their pros and cons. The bone health issue, it's nice to stay off as long as you can when it's time to do it. They all have their pros and cons. The endocrinologists are the people who tend to be the experts in this, and it's constantly changing.
That's to her.
Oh, there you go. You're right? You're the pros. And I noticed at USC the endocrinologists hate Prolia because once you're on, you can't come off.
Yeah, I think Prolia it's a challenging one because if you are somebody who travels a lot, or you're somebody who tends to miss doctor's appointments, and you miss a dose, or you delay it by a couple of months,
you're going to
actually get, it's not just the bone loss, you get rebound fractures of the spine.
Oh my God.
And I've got to tell you, there's nothing worse than seeing somebody who has been otherwise healthy, who bent down to tie their shoes and developed a fracture because they were just late.
Yeah, I noticed many physicians really like it because, so the big one, the Reclast, and this, in all honesty, happened to me, and I was like, oh my God, gets people sometimes really sick. It's an IV infusion. It would be my choice for sure because you do it for 3 years and you get a break. But, oh my goodness. It is kind of a poison in a way. It poisons the cells that eat up the Reclast. It's Zometa, Reclast. And it blew my brain because we use it in cancer all the time for people who have bone metastasis, and hardly anyone reacted ever. And I'm like thinking, well, holy cow. You know, I mean, I don't want to say I was at death's door, but I felt awful for 2 weeks. Chills and exhaustion and body aches, and kidney function was off and struggling to, so the endocrinologist was like, it'll be easier the next time. And I'm trying to get my guts up to do it again. I gotten it.
That's the very rare side of it. So about 25% of people, when they have these infusions, will have some flu-like symptoms. They're usually gone within 2 days.
2 weeks.
So it's unusual. It happens. And sometimes it's more severe if your calcium is also on the lower side going into the infusion.
It wasn't, yeah.
So we always tell people to hydrate and take Tylenol and do all the...
I did all that, yeah. Anyway, but yeah, the point is though, supposedly it gets easier the second go around. So, but I think what you're hearing, there are a lot of options. None of them come without a potential price. All of them have a price, right? So, this is what, and I'm sure you all tell people this too, with everything you do, nothing comes without a potential price. Sometimes it's a very small price, sometimes it's a bigger price. You have to weigh it off, right? What are you gaining versus what might you be losing? And it's a decision between you and your doctor. But it freaks me out how people blow off bone health. There's been a lot of negative publicity about these drugs. We haven't mentioned the thing that freaks everyone out, and that is many of these drugs, I don't know about the Evenity, but the two common ones can cause what's called necrosis of the jaw. It is extremely rare, but when it happens, it is miserable. And I've had it happen in one cancer patient, and, but I've used a lot of these drugs, and I've seen it in N=1, but it's miserable when it happens. So the dentists do freak out about it, definitely. You go, and they're like, oh. So that has caused, at least in the other big thing that has freaked people out is that, all right, you can take reclass, but the bone you're building isn't normal bone, and you're prone to atypical fractures. And maybe, nothing's perfect, but the overall fracture rate is clearly less, right?
Yeah, I think that the decision making is the same as it is for hormones, right? We're always looking at what your risks are without doing anything versus what the risks are of having something icky happen when you take the drug. And I would say for my patients, I would never recommend any treatment where I thought that the risks outweigh the benefits. Of course. And so I think we're just balancing that, and some of the studies about these, atypical fractures of the femur, the long bone of the leg, were in patients who took these medications for a really long time, and they had a big decrease in what's called bone turnover. So bone is always in the process of building up and breaking down, and when the bone gets too quiet, we're at higher risk of these things happening. So part of it is also just making sure that you've got somebody who's got their eye on the ball, who's going to make sure that your bone turnover looks okay, and that your body isn't processing this differently than somebody else's, and they're really looking at you as the patient.
I really feel the endocrinologists do I refer, people just tell me, well, why don't you prescribe it to me? And I'm like, no, I'll prescribe you your hormones, but I really feel these are the experts. The data's changing. And these decisions are complicated in my book.
Lynda, I know this isn't really your area of expertise, but just the last topic that I think we all think about a lot and hear about and do and try, and it's all over our, world. Can you mention or talk at all about peptides and anything under that sphere from, again, your lens and, from how you...
I don't have any experience. I know this is an evolving field, and there are people who've used peptides who feel it has made a big difference, but I don't have any experience. Have you guys had any experience?
So I have a feeling I'm going to get the same answer you are, which is that you just don't know enough yet. And I'm never going to tell somebody who's sitting in front of me and telling me that they feel so much better with what they're doing that it's not making a difference. I also can't.
That it's not doing harm. Yeah. Yeah, I kind of feel, this argument, for example, I'm telling you where this has become very relevant also with the GLP-1 drugs, the Ozempic class of drugs, right? my internist told me, who was not overweight, goes, I went on microdoses, and I'm looking at him going, why? And he goes, I lost 17 pounds and my back pain went away. And I'm giving it to my cousin who has rheumatoid arthritis, and she feels a lot better. And it has just exploded. It's, the GLP-1 drugs were really for morbid obesity and weight loss, and especially for diabetics, right? We have a massive obesity epidemic in the United States, and we are seeing the medical effects of that. And they have definitely had a huge impact on weight loss, the psychology of eating. It affects the reward center, which has a lot to do with overeating.
Remember, we evolved lean. We evolved in most of our history, there was not enough food. And somewhere probably World War II after era, processed foods came into play. So now we have we went from a bunch of malnourished, underweight people to a bunch of malnourished, overweight people, which is worse. And it's not how our bodies evolved to be healthy. So we have a huge health crisis. You have no idea how many health issues we're seeing because of profound obesity in young women. So these GLP-1s have been a game changer, not for everybody, but for a lot of people who are obese. But it's coming out. It's not just about weight loss and diabetes control and cholesterol levels lowering, but impulsive behavior seems to be less. Inflammatory conditions seem to be less. The obsessiveness about food that people complain about. I'm thinking all day long, what am I going to eat? And I can't, and I don't care anymore. I don't think about it so much anymore. It doesn't bother, the psychology of eating, right? And so it is exploding. And now you can buy it yourself, if your doctor cooperates. And so it's going to be interesting to see where it goes. And, in my heart, I have a feeling it's going to be the next statin. In my heart, I feel this is going to be a good thing for a lot of people. But I think it's a little premature to say if what you're taking it to lose 15 pounds so you can wear a bikini this summer, that's a good idea. Because when you stop it, it seems like the effects go away. So when you're on it, you're talking about ongoing use. We have no idea what the long-term effects are going to be. So if you are already a big risk for long-term effects because of what's happening to you, okay. But it's a little nerve-wracking when you're taking it, because you want to get a dress for a wedding, for example, or something. I'm like, wait a minute, let's be a little careful. So, but again, it's one of these things where the train has left the station, and it's in medicine, even the COVID vaccine, right? We don't know the long-term effects of mRNA vaccines. We know we were in a crisis. We know we had to do something, and we know that the vaccination caused plummeting of hospitalization rates. What are the long-term effects? Hopefully nothing terrible, because this technology is staying. It's going to become important in cancer therapy. mRNA technology is here to stay, and is probably going to have a huge role in cancer between you and I. We will find out with time, right, what the long-term effects of this are. There's lots of hysterics about it, but I keep telling people, you're not as brilliant as you think. Time will tell. I know you think you're brilliant and you know exactly, but calm down. Time will tell. We'll see the data when it comes out.
I have one last question, which is specific to your area of expertise. Is it just because we know so many more people, or because I guess they all tell me personally, but are more younger women getting ovarian cancer?
Uterine cancer.
Uterine. So will you talk about that? And maybe
uterine cancer for sure. The other big one's colon. Colon cancer is definitely going. Yeah, I wish I know. So I asked my gastroenterologist this, and I'm like, all right, you're the expert.
Do you see women who come in thinking one thing and it's something else?
Well, I see women coming in with uterine cancer. The uterine cancer question's easy. The uterine cancer is related to obesity, so most of the time. In women who are very overweight, one of the things that estrogen can do, fatty tissue can do, adipose tissue, is make weak, low levels of estrogen. So you have this chronic estrogen production, and it totally screws up ovulation. They don't ovulate properly.
They don't make progesterone. The body just sees estrogen. The uterus begins to overgrow and overgrow and overgrow, and then finally becomes atypical and cancerous. And we have in our clinic 18, 20, 21, 22-year-olds with endometrial cancer, and almost certainly from obesity and anovulation. So this has been one of the unfortunate impacts of our obesity crisis. So uterine cancer is the only one of the gynecologic cancers that is rising in incidence. Ovary is actually going down, and the feeling about that is that we have discovered, I mean, it's been a while now, that ovarian cancer, the bad type, doesn't start in the ovary, it starts in the fallopian tube. And now the practice is, if you ever operate on somebody for anything in the pelvis and they're done having kids, just remove the fallopian tubes. Leave the ovary, remove the fallopian tubes. And a lot of people who decide that they want a tubal ligation instead go for removal of the fallopian tubes instead. So it probably is having an impact. Also, long-term use of the birth control pill also reduces the risk of ovarian cancer. So we are seeing less ovarian cancer with time, less cervical cancer because of the Gardasil vaccine and HPV testing in this country. But endometrial cancer is very much going up, unfortunately. Obesity is part of it.
Does obesity have to do with colon cancer?
So the gastroenterologists feel it does, but you know what my gastroenterologist said? Plastic. Microplastics. And I'm like, how do you know that? You know, I'm like, I look at her and I go, how do you know that, you know? And I mean, I know it's the buzzword. I'm like, how do we know this? And she goes, I just have a feeling. And I'm like, not good enough. But I suspect it is dietary. In my own heart, I don't know how many, I'm sure a lot of you have traveled overseas. Isn't the food a lot better in Europe than it is here? Do you find it tastes better?
Of course.
And I keep going.
Are their rates lower?
My understanding is yes. And, you know, I find myself going, in general, well, not every country follows the same rules.
I mean, like in where you're speaking
I
of.
kind of feel like we don't need to argue and reinvent the wheel. We should just adopt the regulations that are there and go with it, because they've figured it out much better than we have. But it isn't happening. It's very much a corporate America thing. I don't know why the rates of colon cancer are going up, but I think a lot of us are alarmed that it has to do with what we're eating.
It's interesting because there's more testing. There's different kinds of testing that should make similarly, not necessarily the HPV vaccine, but should be trending in the other direction. That's upsetting.
Lifestyle does matter. Yeah. Lifestyle does matter. And we have in this country, I don't know if the physicians in this room agree, kind of lost control of our lifestyle. Not everybody, but in general, I feel like, and even if you have access to good food, I just feel like the amount of stuff that is used in our foods and the degree of pesticides that are used, it's kind of nerve-wracking. You know, somehow we've lost control. Corporate America has won very much when it comes to all this. That's my feeling, yeah.
I just was confused about one thing. So if you're on the patch, but not progesterone, I have my uterus and fallopian tubes are gone, but I kept my ovaries. So I'm just on a patch. But why do you need to lower the patch over time?
You don't have to. You don't have, you know, the data regarding long-term use of estrogen on breast cancer is not available. So, you know, theoretically, if you don't need the higher and you feel just as good with the lower,
Right.
maybe you should think about it. But
But if you feel like very good with the higher and so as you
no, then go with the higher. Okay. I mean, I don't think I can tell you it's dangerous, right? We don't. Sadly, we should know. We should know this.
Are there great studies happening?
No.
That's why we don't know.
Really? That's crazy.
How do you change that?
We all support women's health a lot more than we do, and we encourage other people to do so. Is that a decent answer?
Study on this, right? It's such an obvious thing.
Isn't it? You would be shocked how this is not an area of interest. This is not. Women's health is still very understudied in general. When women share diseases with men, and yes, cancer, for example, like lung cancer and colon cancer, and the GYN cancers, I'm going to be very honest, there is more, because pharma can benefit a great deal from treating women's cancers. There have been much more studies in the female cancers. But it's gotten better. But national funding for the gynecologic cancers, as far as we have this ratio called funding to lethality ratio, how many people die versus the amount of funding per person, and the GYN cancers are rock bottom.
Also, what Tammy was saying about the brain, there's also the heart. There's this amazing doctor at Cedars named Dr. Schufelt. Do you know her?
I've heard the name.
Yeah, and she left Cedars to run the Mayo Clinic in Florida. She's so smart, and she studies like the connection of these different things. And when she left Cedars shut down the whole department because there's no one else with the dual knowledge, or maybe it's degrees
Or interest.
It's interest. It is interest. These studies are not easy to do. You need large number of people studied over a long period of time. So it's a big investment, because you're not going to get the answer in a year.
Right. I'm not even talking about the studies, even though there are like doctors that study like two different things, like the brain and hormones, or the heart and hormones.
So let me just tell you something. I don't know if the endocrinologists have taken up the slack, but in the gynecology world, this was classically the bailiwick of what's called reproductive endocrinologists. And when I was younger, they were brilliant at this. When I was at USC in my early years, they had an amazing department when it came to hormones, hormone replacement therapy, birth control, reproductive endocrinology. And then, what hit? IVF. IVF hit. Where's the money? IVF. The young people, all they want is IVF and to make their fortune. And I keep saying, what about the endocrinology part? That is kind of part of your job, right? They don't take insurance, IVF cycles. It's so upsetting. So there is a doctor at USC, she's in her 70s, but this has been her whole career, and this is her passion, and she's very interested in this too, and has been studying it from her young age, but she's only going to last so much longer, right? She's in her 70s. So I think like even PCOS, and it's a common problem, and it's miserable, and nobody knows what to do about it other than go on the birth control pill. More and more, yeah, and it's a big problem. I mean, they can't lose weight, and they're very prone to, it's miserable, and it's an endocrine abnormality. And I'm like, can't we figure out what to do about this already? There's got to be answers here, but very frustrating.
That's a plastics thing as well.
I don't think so. I don't know what it is. I don't know if you have any theory. I don't know. It's been around a long time, but it is an endocrine abnormality.
I think part of it is also the obesity epidemic.
Makes it more likely.
I think the symptoms are more pronounced when girls are carrying more weight.
I'm sorry?
No, so there's different phenotypes of it, right? But I think told me my whole life. Yeah, and it makes it worse.
No, PCOS is miserable. It's an endocrine abnormality, and many people with it also gain weight much more easily, and can only lose weight by not eating any carbs. But that's not always so easy. It's extremely. So the point is, women's health is very much understudied, and how to fix it. Advocacy. I mean.
So that's my question. How do you? Because I hear your question about dollar per head or.
The funding to lethality ratio.
Yeah, but just stepping back, women are now becoming more than half of the population. So I'm like, how do we advocate for more than half the population, especially our children?
I've thought about this a long time because, in my position, I've pushed women's health very, very, very hard. And, at USC, there's a lot of research programs having to do with the women's cancer, including the early detection piece, because there's a team of people who are extremely interested in this. But what I've discovered, I mean, to my horror, I'll be very honest with you, you know, when I was in college, women were welcome. I mean, I went to an engineering school where there were 9 men to 1 woman. And I was welcomed. And there was like this renaissance, you know, women were welcomed into science and the workforce. And even in medicine, you know, women were entering the field with quite a bit of success and changing the field. Definitely changing. The field improved with the addition of women, because women generally are better communicators, and I think it's important for doctors to be good communicators. And, you know, I noticed men, you know, don't want to talk so much, and women are verbal. And even men, if you sit down and talk to them and explain, appreciate it, you know. So, but it's kind of shifted. There's been some pushback against women for being as successful as they are and making some of the, there has been a pushback against women in our country. Very clearly. We are pushing more into a conservative realm. You know, it comes out in many ways. I don't think I have to expound for you what's happened in our world, right? Women's rights, women's reproductive rights, and in the South, you know, I did my training in Texas, so I have a lot of friends in Texas. You know, and you could argue whether you like the idea of abortion. No one likes the idea of abortion. No one. You know, I never particularly was eager to learn how to do it, but, you know, we have no safety net for the children. So, come on. Before you start hysteric about the fetus, can you maybe worry about the baby? You know? So, but somehow there's been a pushback in women, and everything's kind of been pushed to the, and I am at a loss. I never thought we would get here, but we're here, and I am at a loss other than vote what we can do about it, honestly. But we do have a problem. We definitely, there's an existential threat going on.
Can I give one thing that might be a little bit more positive?
Yes, because I'm not ending on the note that we have an existential problem, and we've all gone to shit.
I do think that, you know, we're seeing a really big issue with NIH funding right now. You know, the shift in politics has made its way to the research world in a really, really big way. And I think that because we have to recognize that that's the climate that we're in, that there are a lot of things, especially in women's health, that are not going to get funded by the government and by government-sponsored agencies. Yeah. But it's opening channels for private folks who are really invested in things to make a really, really big difference. And so, I mean, it's things like what you're doing through education and through advocacy that is tremendous. And then it's donors who are supporting groups and physicians at academic universities who have the opportunity to make a huge impact at this point. And I think that a lot of places are a lot more open now to starting research projects that way rather than through the traditional channels of federal funding. So I don't want to say it's all bleak, but I think it takes people being really proactive.
I'll tell you something. In 1995, my mom was in her 2nd year of cancer, and she switched doctors from a doctor at Cedars to a doctor who has since passed, who was head of gynecologic oncology at USC, a research doctor. And she was like just flummoxed that he had no money. Like he wanted to do something, it was either bring in a fellow or have some funding for a project to study. I think at that time it was platinums, which is now something used in ovarian cancer, standard practice, and at that time it wasn't. And my mom was not an advocate for herself, and she wasn't an advocate for ovarian cancer when she had it. She didn't really want to like be that person. But she was just so overwhelmed by the that idea that these doctors, who are the most brilliant people in our planet in this room right now, didn't have the funds to do what they wanted to do, that they knew would make a difference, that they knew would help women, that they knew would push into a new sort of realm, right? And that was, I guess, you know, I inherited that bug from her. And I'll say that one of the things Stephanie was just saying was that it's not just the lack of government funding and the idea that private funding is helpful, is that doctors and research institutions and the leaders of the institutions are much more open and excited to receive it. maybe less oversight, I don't know, but also I think it's targeted and directed. And I think that makes a really big difference. And when you work in partnership, I found, and I think I can say it as somewhat of a, seasoned vet for doing this for almost 3 decades, when you work in partnership with really smart people in a really research-based academic institution, and you listen to them of what the needs are and what they need and what they want, it's not so big. Like, it's not so overwhelming. It's not, I need $1 billion. It's, no, I need this amount to do this, and then we'll come back when we need more. And it's very tangible. And when we started this foundation, that I was so young, I think that was the overwhelming part until I realized that. And that you can do a lot of really important work, and well, you can give it to people who are doing really important work and know exactly what's happening. And I think, for me personally, in the last 30 years, people have said, why aren't you this big? Like, why don't you want to do this? And don't you want to have clinics all over? And shouldn't you be Susan G. Komen at this point? And my answer was always no, because I want to be able to know, like, the people that we're working with and what they need. And I think the advocacy part comes along with that. Yeah. So it's really finding those people you can work and trust with and know, and then support them.
Yeah, I began by saying the enormous amount of good. There's classically always been work that the government's been interested in, not. The government's a big donor, right? There's a lot of basic things, where the answer actually, the study is much more simple and the answer can be very impactful, that the government's never been interested in, that foundations can make a huge difference in. And, the answer isn't always, you need to do a 20-year study like we did with the answer. And so how with the Lynne Cohen Foundation, it literally was putting together a clinic at both an underserved and a, served, however I say it, population, different strata, focusing on women who carry mutations, bringing them in to see the doctors both on the breast side and the GYN side at once, discussing the patient so the breast doctor doesn't say, you cannot use hormones, and the GYN doctor says, you must use hormones, right? That we don't cause confusion, that we're all on the same page, that we stay up on the data, and that we establish a clinic in underserved populations so that we desperately try not just to treat the patients who show up because they've had a cancer, but their relatives. This all happened because of philanthropy. And the impact was huge. And of course, as we do this, we're now collecting blood specimens and tissue specimens on women who are having risk-reducing surgeries. So now there's, for example, a PhD at USC who has developed a blood test who seems to be incredibly effective at diagnosing high-grade serous ovarian cancer. And we're partnering with other institutions to see if that blood test is positive in the people with the earliest forms of ovarian cancer that we can find sometimes when we preventively remove fallopian tubes from people with the BRCA mutation. And this is how an early detection test is going to happen. This whole thing is privately funded. So, it is rather than aiming for the stars to answer some of the questions that are going to take 30 years, there's things that can just be done on the ground, right? But it is getting together and strategizing. I think all of us who are involved in research know it. Any support of women's cancers is gold right? And use it well. Yeah.
So this is a comment, but along these lines. There are other countries that have hospitals that are doing research in women's health that is pretty unbelievable. I sit on a board of one of those hospitals that's not in this country.
Which country?
In Israel.
Israel.
So Shiva Medical Center is doing tremendous work in
yeah.
women's health that is so far and beyond anything we're doing here because they don't have an FDA. They don't. They get through these clinical trials like literally in a week you can get approved for something, whereas here it would take years. So they're saving lives in ways that we aren't. But what I'm always baffled by is I feel like the coordination amongst different hospitals and different research institutions is not very good. It's almost competitive.
It is competitive. There's few dollars they're all going for.
So the question is, if somebody's doing something incredible in another country and someone here is pursuing the same thing, are you seeing what I'm seeing, which is that the coordination and communication isn't there, and perhaps we could make more strides if it was actually there?
For sure.
Right? So how do we my question is,
How do you break the silos? Is that what you're asking? Yeah. Yeah, I mean, from my point of view, I just want the progress. I don't give a hoot if it, who does it. I'm no ego in the game, right? It's just, can we help the patients, please? That I'm the one, as you are, we're dealing with seeing people in front of us suffering, right? We want things better. The PhD side, it's a little bit, sometimes a little bit different. But just so you know, Amy doesn't know this, but we had a meeting literally 2 weeks ago, UCLA, us, Cedars, USC, UCLA, Cedars, Stanford remotely, to talk about the early detection piece, what we're all doing and how to share resources. And we got together and it's like, can we do a California consortium? Every single MD there was on board. We talked about people were floored to hear about the Lynne Cohen clinic there, going, what? You have blood? You have tissue?
Part of the problem is that you don't have that many doctors. In my experience, I've met a handful of them, not all of them, but more than most of us, like Lynda, who have no ego in the game. And so many do. And it's a huge buzzkill because that's the game changer. So it's someone like you, an advocate, finding those doctors who don't have an ego in the game and are just about progress and working to find ways to get them together. And I'm happy to do it with you. But I think I'm in. But I think that's the piece. And it's to what Kim was asking. It's saying I want to spend a X percentage of my time on a cause that matters to me, and I'm going to find the people who are doing the work who don't have an ego, who don't care about their name being, the person who founded this. They just want to help, and they just want to make a difference for the people in front of them that they're seeing. And I think that's in my opinion how you do it. People are leaving, I know, and Lynda has to get back to the hospital. So I just want to say thank you, Dr. Roman. Thank you. You are amazing. And thank you to you, Shu. Thank you. I think one of the wonderful things about doing these events, and Marina stepped out, and having a host like Marina, is that she asked me, who should I invite? I said, just the people that you think are your friends and also interesting and different, and the conversation will be really robust. And it is today, so thank you for contributing. Like we said, I have zero ego. Lynda has none either. So the idea that we can collaborate and talk and say, I don't know, that's not my specialty, you're an endocrinologist sitting right here, Stephanie, you talk about it, is wonderful. And so Marina's in the kitchen, I'll thank her with a hug. But thank you to Marina, thank you for coming. And this is what we do. Like I said, Christina and I made a decision that we don't really want to spend the insane amounts of time putting together huge, benefit events, which we do once in a while, but it's just not time well served in our opinion. And we really love these kinds of things. And I hope you'll be supportive by coming, by figuring out how to be an advocate first and foremost for yourself, and secondly for a cause that matters, and support the work that we do, because I promise you it's really important. And we are looking at the women in front of us. And I think that we can all do that. And I hope when you leave today, like I said at the beginning, you know a little bit more about something you didn't know so much about when you got here. And then anyone in your life who has that question, instead of saying, I don't know, you can call me, but that you at least know where to start. And I think that's the goal, right? And so I hope that we've pushed your starting line a little bit farther forward. Marina, thank you. I thanked you when you were standing here. Thank you so much for hosting.
And if you're still hungry, or if you didn't get a chance to eat,
Because you're at the Cohen's house, there's lots of food.
I always want to make sure.
Per usual, yes. But thank you. Thank you for bringing together such a wonderful group of women. This was a wonderful conversation. And until next time, thanks, ladies.